there is no leakage right after the occurrence of perforation, but as time goes on, air leakage develops, and followed by a fluid leak, and finally the leakage of fecal material. If the air leakage is very large, then tangent pneumoperitoneum develops, followed by abdominal compartment syndrome, which include cardiovascular compromise, renal impairment, GI perfusion impairment, which can induce multi-organ failure. And if the fecal fluid leaks out into the peritoneum, peritonitis may develop, which can be followed by sepsis. And if the perforation occurs at the mid or distal rectum, retroperitoneal perforation may occur rather than intraperitoneal perforation. And in this case, retroperitoneal abscess may develop rather than peritonitis. So perforation should be managed according to this pathogenic process. For example, needle aspiration should be performed in case of symptomatic tangent pneumoperitoneum, and antibiotics should be administered for treatment of peritonitis with or without sepsis. And drainage may be necessary in case of retroperitoneal abscess. And in addition, the treatment of perforation itself is very important for management of leakage. So when perforation occurs, the patient position should be adjusted to make the perforation be located at the anti-gravity direction, so that the leakage of fecal material can be minimized. And then perforation should be closed endoscopically by using endoscopic clipping or something like that. But if there was already a significant amount of fecal material leakage into the peritoneal cavity, then endoscopic closure cannot interrupt the progression of peritonitis even after successful endoscopic clipping. So in this case, surgery should be considered for irrigation of already leaked fecal material. As I mentioned right before, needle aspiration should be performed for symptomatic pneumoperitoneum by using IV catheter or something like that. And tangent pneumoperitoneum can occur during the endoscopic clipping trial because the amount of inflated air during the long time of clipping trial can be very large, and it can be leaked out through the peritoneal cavity, thereby causing tangent pneumoperitoneum. So you must be very careful. So if the clipping trial can be long, then you should perform needle aspiration first, so that leaked air can be gone out through the IV catheter. And endoscopic through the scope clip is the most commonly used method for endoscopic closure of perforation, and through the scope clip is usually indicated for perforation of 1 centimeter or less or smaller. And there are several sizes of clips. Some of them are locatable and the others are not. So you can select the most appropriate clip according to the size, location, and morphology of perforation. Clipping is maybe actually difficult if you perform clipping at the center, at the middle of the perforation, where the mucosal defect gap is quite wide. So clipping should be performed from the edge of perforation, where the mucosal defect gap is relatively narrow. Once the first clip was applied successfully, the next portion can become narrower, so you can perform the next clipping relatively easily. In this way, we can close the relatively large population quite effectively by using sequential clipping one by one. As I mentioned, colorectal ESD population rate is about 5%, but if you use endoscopy through the scope clipping successfully, surgery was required only in about 1%, which means endoscopy through the scope clipping is very effective for the management of colorectal ESD associated population. This is off the scope clip, OTSC. OTSC is usually indicated for management of population of 1 to 2.5 centimeter in diameter. But colon ESD population is usually small, and colonoscope should be withdrawn and reinserted after the installation of OTSC at the tip of the endoscope, which is quite cumbersome. And colon ESD population is more common in the proximal colon, but the insertion of colonoscope with OTSC at the tip of the endoscope up to the proximal colon is quite difficult. So OTSC is not actually commonly used for management of colon ESD population. Then when do we have to perform endoscopic clip closure? In general, the sooner the better, because immediate endoscopic closure could minimize the leakage of fecal fluid, thereby interrupting the progression of peritonitis. But peritonitis may progress if endoscopic closure is performed after the significant leakage of fluid and feces into the peritoneal cavity. So in this case, you should consider surgery for intraoperative irrigation of already leaked out fecal material. But the sooner clipping is not always the best. Further dissection may be difficult in some cases once clipping has been applied, like this picture shows here. In this type of situation, the applied clip may interrupt, may make the knife manipulation quite difficult. So in this type of situation, further dissection should be performed somewhat more before clipping. And during the dissection, the patient position should be adjusted so that the bowel contents could be shifted at the opposite side of the wall to minimize the leakage of fecal material through the perforation. This is a large LSD non-granular type tumor, and during ESD, a small ESD perforation occurred. And because the perforation was located at the dissection, just at the dissection front, clipping right this time might have interrupted, might have made the knife manipulation very difficult. So I performed dissection somewhat more before clipping, and afterwards I applied several clips, and complete procedure was successfully finished. If clipping was not applied right after a colonic perforation, and then is there any time limitation for the reinsertion of a second colonoscopy with delayed clipping trial? Although the ESGE says the second look endoscopy insertion with a delayed clipping trial can be performed within 4 hours after perforation. I think this recommendation does not have sufficient scientific evidence. I think more important factors to be considered include the appropriateness of the size of perforation for clipping, and adequacy of bowel preparation, and presence or absence of peritonitis symptom or sign, and the available endoscopist expertise level. For example, if bowel preparation is very poor, then even short time after, I think we do not have to perform reinsertion. We'd better send the patient to the surgical department for surgery. This is the data of my center. In our data, surgery was also necessary in case of clipping failure for microscopy, endoscopy, intra-procedure perforation, and surgery was also necessary if peritonitis symptom developed. So in summary, surgery should be considered for large perforation with clipping failure and those whose conditions deteriorate with conservative management even after endoscopic closure, and delayed perforation with generalized peritonitis or ongoing sepsis. American Gastroenterological Association AGA recommendation is quite similar like this. I will show you several population cases. So during hybrid ESD, a small perforation occurred at 2:40 in the afternoon. Because the bowel preparation was very clear and there was no leakage of fecal material, I applied several clips just within 2 minutes after bowel preparation. And finally, the perforation was completely closed by multiple clips within 10 minutes of perforation. In these patients, although some amount of pneumoperitoneum was observed, there was no tangent pneumoperitoneum, no severe abdominal pain, so needle aspiration was not performed, and just NPO and antibiotics were administered, and because there was no severe symptom, the patient could start soft diet on the post-operation day 2, and the patient was discharged on the post-operation day 3. This is another case. Although the ESD ulcer base shows a little dirty surface, there is no definite visible perforation here. But the patient complained of abdominal pain and tenderness after colorectal ESD. So we checked simple X-ray, and there was a large amount of pneumoperitoneum, it was tender pneumoperitoneum, and so we performed needle aspiration for air decompression. But I did not perform second loop fluoroscopy reinsertion with a delayed clipping trial because there was no definite perforation evidence on the post-ESD ulcer. So the patient's abdominal pain improved right after needle aspiration, and there was only mild symptom, the patient could start sips of water on the post-operation day 3, and the patient could be discharged on the post-operation day 4. This is the third case. This is not colorectal ESD associated perforation, but a diagnostic fluoroscopy related perforation, not in my center, but at the other hospital. I was consulted for endoscopic closure for this diagnostic fluoroscopy perforation. Because the other hospital was quite close to our center, I performed second fluoroscopy just within 1 hour after perforation, and I applied clipping quite successfully. So I thought that the clipping procedure was very good, and I expected the patient's clinical course could be quite favorable. But unlike my expectation, the patient's abdominal pain did not improve. The patient complained of abdominal pain continuously even after clipping, and tenderness, rebound tenderness, and fever up to 38 degrees Celsius continued for over 2 days. So at that time, I thought that there was already a significant amount of fecal fluid leakage through the perforation before my clipping trial. and peritonitis was ongoing even after my successful clipping trial. So I consulted to the surgical department, and exploratory laparotomy was performed, and the surgical field showed mild to moderate swelling of intestinal wall, which suggests ongoing peritonitis. So the surgeon performed a massive irrigation to remove the fecal material from the peritoneal cavity. After surgery, the patient's fever and abdominal pain subsided gradually, and the patients could be discharged on the post-surgical day 5. So, as I mentioned, if the patient condition deteriorates, surgery should be considered even after successful endoscopic clipping. Okay, now let me move on to the bleeding. So there are also two types of bleeding, intra-procedural bleeding and delayed bleeding after completion of colorectal ESD. And there are several types of endoscopic hemostatic methods. So in case of colorectal ESD, coagulation hemostasis by using hemostatic forceps or mechanical hemostasis by using endoscopic clipping are the two most commonly used methods. So there is a mild continuous active bleeding at the colorectal ESD surface, and clipping was performed, and hemostasis was successfully achieved. During dissection, sometimes bleeding can occur, and if bleeding occurs, hemostatic forceps can be applied like this video clip shows, and then water is injected to see if the bleeding was stopped successfully or not. If the bleeding stopped successfully, then soft coagulation can be delivered to coagulate the bleeding vessels. And if actually this is not very large, but let's say this is very large vessel. So if you see a quite large vessel, then pre-coagulation before the occurrence of bleeding can be very useful for maintenance of clear dissection field. And to minimize the bleeding risk, we should know the histological structure of GI tract wall. So this is the proper muscle layer, and this level is submucosal layer, and these are perforating vessels. And as you can see here, there is only a small number of small vessels at the deep submucosal layer, but in comparison, there are relatively higher number of vessels in the superficial submucosal layer. So if you perform superficial submucosal dissection, there could be multiple episodes of bleeding compared to here at the deep submucosal layer. So this is a muscle layer, and the dissection level should be at the lower third level of the submucosal layer to minimize the risk of bleeding. Prophylactic clipping was not effective, was not useful to decrease the delayed bleeding incidence after polypectomy of small polyps. But prophylactic clipping after EMR or ESD of large polyps over 2 centimeters in size, especially for proximal colony lesions, could decrease the incidence of delayed bleeding. But personally, I think this approach in all proximal colony lesions may be somewhat cost ineffective. There are two types of vessels. The first one is simply exposed vessels, and the second is like these figure shows here, cut vessels. So in my center, we analyzed the risk factors for delayed bleeding, and the cut vessel is a definite risk factor for delayed bleeding. So I think if you want more cost-effective prevention of delayed bleeding after ESD, then I think we may consider not prophylactic clipping in all ESD cases, but we can consider selective coagulation for high-risk groups such as cut vessels. The most current version of Olympus endoscope has a function called red eye chromatic imaging (RDI). In this RDI image, the bleeding point can be visualized more clearly as a yellow color, and yes, this short video clip shows more clearer visualization of bleeding point compared to white light image. So this is a case report on the usage of RDI in the rectal ESD. So this is a 20 millimeter 1S tumor in the rectum in contact with internal hemorrhoid here. Submucosal injection was performed after assessment of deep vessels using RDI to prevent injection site bleeding. A circumferential mucosal incision was made without significant bleeding by avoiding submucosal vessels. Because RDI can visualize submucosal vessels more clearly, Olympus insists that it is very useful to assess, to predict the location of submucosal vessels like this. And when bleeding occurred during ESD, RDI image, the bleeding points could be easily identified and could achieve targeted, quick, and effective hemostasis by using RDI image, like this short video clip shows here. So in conclusion, the application of RDI in full time during all steps of ESD could be useful in not only identifying bleeding points, but also preventing bleeding by avoiding deep vessels. So I'd like to summarize my talk. Two major complications associated with colorectal ESD are perforation and bleeding, and most of these complications can be managed by endoscopic therapies. Thank you so much for your time.
Thank you so much, Professor Jeong-Sik Byeon, for the this lecture. Now we have